In chapter 19, we're going to talk about heart failure and dysrhythmias. So, heart failure is the inability of the heart to maintain sufficient cardiac output to meet the body's metabolic demands of tissues and organs. And when the heart's failing to pump blood, this results in congestion of blood flow in the venous circulation of either the pulmonary or the systemic circuits, depending on what side of the heart is failing to adequately pump blood. Throughout the U.S., there's an increasing incidence of heart failure, and it's the most common reason for hospitalization in those 65 years of age or older. Now, we're going to first talk about systolic dysfunction. So, systolic dysfunction is typically caused by myocardial infarction, and remember, systole or systolic refers to a state of contraction. So, systolic dysfunction is due to reduced contractility, which is evidenced by a lower ejection fraction, reduced inotropy during systole, and therefore a reduction in stroke volume and cardiac output and potentially even blood pressure. Now, this impaired contractility involves loss of cardiac muscle cells, or it could also be caused by beta receptor downregulation or reduced ATP production. But in either case, in any of these three events, what we find then is there's reduced contractility of the heart muscle, and therefore a lowered ejection fraction, so lower stroke volume and lower cardiac output. Now, this differs from diastolic dysfunction because diastolic dysfunction is typically caused by coronary artery disease and hypertension, and it's more likely to develop in elderly, women, and those without history of myocardial infarction. But ultimately, diastolic dysfunction is a disorder of myocardial relaxation, so that the ventricles are actually excessively non-compliant, and therefore they don't fill effectively. So your ventricular end diastolic volume is lower due to the fact that the ventricles can't stretch and appropriately fill with blood. And by having a lower EDV, then you have a lower stroke volume and lower cardiac output as a result. Now, by decreasing cardiac output, this results in congestion and edema. Now, the edema can occur in the lungs or peripheral tissues depending on where this might be occurring, like which heart chamber is dysfunctional. Now, some of the compensatory mechanisms of heart failure involve your brain, kidneys, and the heart itself. And we'll first talk about the brain. So we know that with heart failure, you have a reduction in the ejection fraction, stroke volume, and therefore cardiac output. And we know that cardiac output is proportional to blood pressure. So with heart failure, you should expect to see a fall in blood pressure. So we have this baroreceptor response by our carotid bodies, which sense a fall in blood pressure. This results in an increase in sympathetic nervous system activation by the medulla oblongata. And so the compensatory response of your nervous system is that the nervous system will stimulate the heart to beat more quickly, so increase in heart rate, as well as increase its force of contraction through increasing sympathetic responses. So the kidneys then can respond to heart failure through the RAAS system. And remember, the kidneys also have basically blood pressure receptors or baroreceptors. And what happens is if blood pressure is too low in the kidneys, then we can actually activate our RAAS. Remember, that's the renin-angiotensin-aldosterone system. So the kidneys will release the hormone renin when blood pressure is low. And so ultimately the effect of this renin is that we end up getting more fluid retention. And it comes in a variety of ways. We talked about how angiotensin 2 stimulates thirst, or aldosterone increases sodium reabsorption, or antidiuretic hormone increases water reabsorption. But all three of those would actually increase retention of fluid by your body. And if you have more fluid in your blood, then you're going to have an increase in preload, so more volume of blood being sort of filling your heart chambers during rest. So this is sort of synonymous with end diastolic volume. And we know that if you increase preload and increase end diastolic volume, that can increase cardiac output through the Frank-Starling law of heart muscle contraction. Now, in terms of the heart itself, what we find then is that with an increase in ventricular wall tension, this can actually stimulate the growth of new cardiomyocytes, or heart muscle cells, and so that can lead to heart muscle hypertrophy. And by having more heart muscle available to contract over time, like this is more of a long-term effect of heart failure, over time that can lead to an increase in cardiac output as long as there's not too much hypertrophy. So just keep in mind with heart failure, there's three main compensatory responses. It involves the nervous system, which is the most rapid, the kidneys, which would be the second most rapid, and then an increase in the size of the heart itself through hypertrophy or cardiomyocyte growth, which would take the longest. But it's a mixture of all three that can lead to an increase in cardiac output to help reverse the effects of heart failure. Now, some of the clinical manifestations of heart failure you should expect to be consistent with lower cardiac output. So it turns out that left ventricular failure is the most common, and we'll talk about left versus right-sided heart failure later. But the forward effect of this is that we have insufficient cardiac output. So if the left ventricle can't effectively pump blood out through the aorta, well, the forward effect, so what happens downstream of the left ventricle, is that you have less blood being ejected by the heart, so poor cardiac output. And this insufficient cardiac output can manifest itself as confusion, fatigue, tachycardia, reduced urine output, and poor peripheral circulation. Now, the backwards effect of left-sided heart failure, or left ventricular failure, would be congestion of blood in the lungs. So we talk about how if the left ventricle receives blood from the left atrium, which is receiving blood from the pulmonary veins, and those are actually bringing blood away from the lungs, well, if the left ventricle is failing to move that blood along, then blood's backing up in the pulmonary circuit, so we get this congestion of blood there in the pulmonary circulation. So in terms of the left-sided heart failure, what this flowchart shows then are the backwards and forwards effects of left-sided heart failure. Now, this one's just saying specifically left ventricular failure, but we'll just generalize and call this left-sided heart failure, which would include left and right atria. I'm sorry, left atrium and left ventricle. Now, some of the forward effects of left ventricular failure, well, we know the left ventricle pumps blood to the aorta, which then brings blood throughout the systemic circuit. So the forward effect of left ventricular failure would be a reduction in cardiac output, so decreased tissue perfusion throughout the body, right? All the systemic circulation would have a decrease in blood flow due to that decrease in cardiac output because the left ventricle is failing to keep that blood flowing. Now, one of the other forwards effects of left-sided heart failure is that by reduction in blood flow to the kidneys, this causes activation of the RAAS, or renin-angiotensin-aldosterone system. So the kidneys release renin, which then stimulate the retention of fluids by your body. And this fluid retention then can lead to left ventricular preload, which we'll come back to here with the backwards effects. So knowing that the left ventricle receives blood from the pulmonary circulation, because the right side of the heart pumps blood to the lungs, whereas the left side of the heart would take that blood from the lungs and then pump that out to the rest of the body. So the backwards effects then are going to affect basically the pulmonary circulation. So due to a decrease in ejection fraction, so that the left ventricle is not pumping out as much blood, you're going to see that we see an increase in left ventricular preload, which means that there's more blood in the left ventricle. This is going to increase left atrial pressure because blood's now backing up into the left atrium. And that's going to lead to an increase in pulmonary pressure because then blood's going to back up through the pulmonary veins into the pulmonary vessels. And that pulmonary congestion can lead to things like pulmonary edema. So that's one of the backwards effects of left-sided heart failure. Now, what this can also affect then is also, surprisingly, the right side of the heart. And it makes sense, though, if you think about it, because the right side of the heart pumps blood to the lungs, but if the left side of the heart is not, moving that blood along, and blood's backing up in the lungs, then this is going to put a lot of ventricular afterload on the right ventricle, which means the right ventricle has to work harder to pump blood to the lungs if blood's backing up there. So then what we see then is right ventricular hypertrophy, where over time, the right ventricular muscle gets thicker in order to accommodate for this increase in afterload or increase in diastolic volume, because it's trying to force that blood through the pulmonary circulation, and the blood's backing up in the pulmonary circulation due to left ventricular failure. Now, some of the signs and symptoms of left-sided heart failure we see here, the backwards and forwards effects. Now, we'll talk about the forwards effects first. Now, the forward effects of left-sided heart failure would relate to things like fatigue, which makes sense. You're not going be able to supply your body's tissues with enough nutrients and blood flow to support their metabolism. This is going to lead to fatigue all over your body. Oliguria, an increase in heart rate, which would be a compensatory response of heart failure. Faint pulses, and then some more cognitive signs like restlessness, confusion, anxiety. And this comes due to the fact that if the nervous system's not receiving enough blood flow, some of the higher brain centers start to shut down. And by a reduction in cognitive processes, you see restlessness, confusion, and anxiety due to the decrease in blood flow from the left ventricle. Now, some of the backwards effects of left-sided heart failure would be things like shortness of breath on exertion, so dyspnea on exertion, orthopnea, cough, nocturnal dyspnea, so basically, difficulty breathing at night, cyanosis or bluing of skin, as well as basilar crackles. Basilar crackles is sort of like a crackling noise that you can hear emanating out of the lungs. And these basilar crackles result from pulmonary congestion because if blood's backing up in the pulmonary circulation, then you get an increase in pulmonary blood pressure, which then could force more fluid into the spaces of your lungs. And so what happens then is that by having a lot of fluid in your alveoli and smaller bronchi, this creates a lot of noises due to opening and closing of those airways from fluid, and this causes basilar crackles, which some people claim sounds like pop rocks in their mouth, but the noise is actually coming from the lungs, but you can hear it coming out of the mouth. Now, for right-sided heart failure, we're talking about damage to the right atrium and right ventricle. Now, this leads to pulmonary disorders because what we find then is that if the right side of the heart can't pump blood to the lungs, then you're not getting an adequate, oxygenation of that blood. Now, this leads to right ventricular hypertrophy, where the right ventricle might try to increase in size and effectively pump blood to the lungs. Now, some of the backwards effects of right-sided heart failure would be things like congestion in the systemic venous system, because we know the right side of the heart receives blood from your systemic veins, which all converge into the superior and inferior vena cava. Well, if blood's backing up into the veins beyond the superior and inferior vena cava, then what we see then is just basically systemic venous congestion, which can lead to things like jugular vein distension, hepatosplenomegaly because of venous congestion in the spleen and liver, edema throughout the body, because if you have blood backing up in veins, you're going to increase venous blood pressure, which can force more fluid out through your capillary beds, causing an increase in edema systemically or throughout your body, and especially edema in the abdominal cavity. Due to a backup of blood in the spleen and liver, what we find is that through the hepatic portal circulation, you see a lot of fluid buildup in the abdominal cavity, and we call that ascites. So edema in the abdomen is ascites, and this can be a result of right-sided heart failure as well. One way to test for right-sided heart failure is this hepatojugular reflex test. And so what you can do here is if you push on the abdomen right by the liver, if blood is backing up in the right side of the heart, then you should expect then that by pushing on the abdomen, this might force blood towards the heart, but then the blood might go through the right atrium up into the jugular vein. So there's this hepatojugular reflex test where if you push on the abdomen and this causes distension of jugular veins, what this suggests then is that the right side of the heart can't keep up with that increase in venous return, which suggests right-sided heart failure. Now, some of the forward effects of right-sided heart failure would be, low output to the left ventricle, which also leads to low cardiac output, and then all of those signs and symptoms we talked about earlier due to decreasing cardiac output could also be caused by right-sided heart failure. So looking at right ventricular failure or right-sided heart failure, the forward effects here would be we'd have a decrease in output to the lungs, which is also a decrease in output to the left ventricle, which means that we have decreases in left ventricular cardiac output and a decrease in tissue perfusion throughout the body. And like left-sided heart failure, this also leads to a decrease in blood pressure, which then causes an activation of the RAAS by the kidneys, causing fluid retention, which also leads to right ventricular preload. Now, in terms of some of the backwards effects of right ventricular failure, what we find then is that due to a decrease in ejection fraction from the right ventricle, we see right ventricular preload, or blood backing up in the right ventricle, which causes blood to back up in the right atrium, which then causes blood to back up throughout systemic veins, and that leads to all the signs and symptoms we talked about earlier, like jugular vein distension and hepatosplenomegaly and ascites, as well as systemic edema. So you can see here, this is not adiposity, by the way. So what this is showing this individual is not someone who's obese, but rather this is edema throughout their tissues. And you have such widespread edema because if the right side of the heart can't effectively pump blood along, that means that venous blood is backing up throughout systemic veins, causing an increase in venous pressure and potentially fluid being forced out of capillaries into tissues throughout the body. That's why we see, the edema and especially ascites here in this individual. So you see hepatosplenomegaly, or basically increase in the size of the liver and spleen due to a congestion of venous blood in the hepatic portal circulation. There's some anorexia here due to fluid overload as well. Subcutaneous edema, like we talked about, and jugular vein distension is one of those classic signs. The reason why the jugular veins are distended particularly is that they're pretty superficial in the neck, and that's typically also an easier vein to see. Someone doesn't need to take off their clothes to see jugular vein distension. Obviously, there will be other veins in the body that are also distended, but jugular vein distension is easy to identify on exposed skin of the neck because the jugular veins are superficial there. Now, the forward effects of right-sided heart failure are also very similar to left-sided heart failure. So, like left-sided heart failure, we saw fatigue, oliguria, an increase in heart rate, and that was the nervous system's compensatory response, faint pulses, restlessness, confusion, anxiety, and these all come about from a decrease in cardiac output. Now, there's a decrease in cardiac output from the left side of the heart because there's a decrease in cardiac output from the right side of the heart. So it's all interconnected here. Now, there are different classes and stages of heart failure, and one of the ones we can use to kind of describe whether someone has the signs and symptoms of heart failure is this idea of FACES. Now, FACES is an acronym for fatigue, activity limitation, congestion, edema, and shortness of breath. And the severity of each of these, like so the severity of fatigue, activity limitation, congestion, edema, shortness of breath, suggests sort of the stage of heart failure or the class of heart failure. And that's this FACES idea. There are other diagnostic assessments as well, like X-ray and echocardiography to figure out, how much hypertrophy is undergoing in the heart, or whether the heart muscle is contracting at all. You can also look at B-type natriuretic peptide levels because if the atria are stretched due to congestion of blood, whether it's the right or left atria, what you can find then is an increase in this B-type natriuretic peptides, which could tell you whether this is acute or chronic heart failure. You won't see B-type natriuretic peptide levels unless this is chronic heart failure because these natriuretic peptides or atriopeptins are released due to chronic stretch of the atria. And the severity of symptoms used to identify those four classes of heart failure help determine prognosis, therapy, and monitoring of the patient based on the class or stage of the progression of their heart failure. In terms of treatment of heart failure, it's basically aimed at improving cardiac output, and this can be achieved with like positive inotropic agents, agents that help increase heart muscle contractility, like digitalis. Digitalis is a drug which is derived from a plant toxin called digitoxin that comes from a flower called foxglove, and this particular plant drug helps improve cardiac output by increasing heart muscle contractility. So it's a positive inotropic agent. You also want to inhibit the sympathetic compensatory responses because if blood pressure is too low, you might find then that you could see an increase in heart rate. However, what we do understand about how the heart works is that if heart rate is too fast, this actually leads to decreases in cardiac output by ineffective ventricular filling. So what you might find then is if someone has tachycardia as a consequence of their heart failure, a beta blocker could actually help improve cardiac output by helping to slow down the heart rate. That way there's enough time for the heart chambers to effectively fill with blood, and in conjunction with a positive inotropic agent like digitalis, this can actually help increase heart muscle contractility to force that blood out and actually improve cardiac output, which sounds counterintuitive, but it also makes sense. So other things that can improve contractility, we talked about digitalis, Other cardiac glycosides, beta agonists can also improve heart muscle contractility. ACE inhibitors as well, because you want to prevent fluid overload. So things that can actually prevent the production of angiotensin 2, like blocking the enzyme ACE, can prevent those angiotensin 2 effects and prevent the fluid overload that actually can complicate heart failure. Or if there's heart failure that coincides with a dysrhythmia, a pacemaker could be effective. And these pacemakers might help effectively synchronize heart muscle contractions. That way, you can improve cardiac output in those individuals. Okay, we're going to pick up here talking about the cardiac dysrhythmias, also called arrhythmias. And a dysrhythmia or arrhythmia is an abnormality of cardiac rhythm. And there's three major types of dysrhythmias. It could be due to abnormal rates of sinus rhythm, abnormal sites of electrical activity. We call these ectopic sites of activity, where impulses of electrical activity start in a different area than where they normally start, or disturbances in the conduction of those electrical impulses. And this could relate to things like block. Now, the dysrhythmias are significant for a variety of reasons. Like, for one, they can indicate an underlying pathophysiological disorder, and they can also impair normal cardiac output. Now, some arrhythmias also increase the risk of clot formation, which can lead to pulmonary or systemic embolisms. Now, the first type of dysrhythmia we'll talk about is reentry, and reentry is associated with tachydysrhythmias, and these cardiac impulses continue to depolarize in a part of the heart after the main impulse has finished its normal path. So it's almost as though an echo of the original electrical impulse is coming back and causing a new electrical impulse to start. And so what happens is this comes through and reactivates the heart along its old conduction pathway, and this leads to sort of like echoes and echoes and echoes of electrical activity. This can be caused by myocardial ischemia or electrolyte abnormalities, and often what this can look like on an EKG is multiple wavelets that chase a tail of a particular wave. So what this looks like here then is red is the initial depolarization, or sort of like the normal pathway of depolarization along the heart. So we know it's going to go from the sinoatrial node towards the AV node, down across the heart, and then back around. Now with reentry, what can happen then is instead of that depolarization just dead ending and stopping somewhere along the electrical conducting pathway, what can happen then is that you might have some depolarization that can re-enter the old pathway and then start to spread across on different parts of the heart. And you can imagine why this would be significant, because now you're effectively stimulating another electrical impulse, but in an abnormal way. So you're going to get not only abnormal electrical activity, but also abnormal heart contractions. So looking at this slide here, what we see is a standard ECG strip, or electrocardiogram strip. And what we find then are amplitude changes of voltage over time. And so what this is looking at is basically changes in the electromagnetic fields as measured on your skin over time. This is due to heart muscle contraction or heart electrical activity. Now, what we find then is on a normal EKG, you find three main waveforms. You got the P, Q, R, S, and then T waves. So P wave is smaller. You get the QRS wave, which is like this taller peak here, and the T wave is this larger sort of hump. And the P wave is associated with atrial depolarization. The QRS wave is associated with ventricular depolarization, and then the T wave here is associated with ventricular repolarization. Now, on all of these ECG strips, time is standardized. And so all of these little squares here represent a unit of time that has passed. So if you count the number of squares between these different electrical events, you can figure out how much time has passed between the different electrical events of a normal ECG here. So if we zoom in on one of these little time squares, what we find then is that each large square here represents 0.2 seconds. So what this is 200 milliseconds. And so what this means is if you have a peak here and a peak here, and we count, okay, here's 0.2 seconds, Here's another 0.2 seconds, and that's 0.2, and that's 0.2, and that's 0.2. Well, that's 5 little 0.2 second intervals, which equates 1 second. So we see that there's 1 full second between each QRS wave. In fact, there's a 1 second between the peak of each R here wave, and that means that this individual's heartbeat or heart rate is 60 beats per minute. Because if you have 1 beat every second, then that's 60 per minute. So there's actually an easier way to calculate this, and all you need to do is actually count the number of big squares here between each peak of the QRS wave. So you have 1, 2, 3, 4, 5, and if you divide the number of big squares into 300, so 300 divided by the number of big squares between each peak here, that gives you a really quick estimate of beats per minute. So if you take 300 divided by 5, you see that that's 60. And so we see here really quickly it's 60 beats per minute. This only works, though, if someone has a normal sinus rhythm here. So that means that you need to have a constant number of intervals between each of these peaks in order for that estimate to work. Otherwise, if this interval is varying, like if the distance between this peak and this peak is different between this peak and that peak, then your estimate's going to be off. Each of these smaller squares here represents 0.04 seconds. And just knowing what these time intervals represent, you can get a pretty good estimate about the time that takes between each of these particular heart events. So a normal sinus rhythm is a rate between 60 and 100 beats per minute. We call this a regular rhythm. Then it starts in the SA node and follows that normal pathway. So it goes from the SA node through the internodal pathways to the AV node, to the AV bundle, bundle branches, Purkinje fibers, or subendocardial conducting pathway. The P wave precedes every QRS complex, which should be followed by a T wave. And so we actually can measure these intervals between these different waves too. So we have a PR interval, so it's a distance between the P wave and the beginning of the middle of your QRS wave. We have the QRS interval, so the length of that QRS wave, as well as a QT interval, or basically the distance between when the ventricles start to depolarize and start to repolarize. Now, we see again, this is a normal sinus rhythm. And you can tell it's normal sinus rhythm because, first of all, we have all of our normal waveforms. So we have a P wave, QRS wave, and a T wave, followed by a P wave, QRS wave, and a T wave. It's also normal in the sense that all these intervals are the same distance. In fact, if we wanted to calculate this individual's heart rate just by looking at the standard ECG strip, what we find then is that there's 1, 2, 3, 4, approximately 4 large squares between each of these QRS peaks. So if we take 300 divided by 4, that's 75 beats per minute. And that gives us an estimate of what their heart rate would be. Now, sinus tachycardia is an abnormally fast heart rate. We know that the intrinsic heart rate generated by the SA node is about 100 beats per minute. So if you have a heart rate faster than 100 beats per minute, we call that sinus tachycardia, and that's at rest. So if someone's resting heart rate's faster than 100 beats per minute, that's sinus tachycardia. And it can be a compensatory response to an increased demand for tissues, so you might want to have an increase in cardiac output to meet the metabolic needs of your tissues, or due to a reduction in stroke volume. So that if you have less stroke volume, then you're going to need a faster heart rate to have the same cardiac output. Now, this usually occurs from an abnormal activity of sympathetic nervous system activation. So too much sympathetic nervous system activation can take your heart rate above the normal resting range, above 100 beats per minute, which would be defined as sinus tachycardia. And the treatment for sinus tachycardia is really just aimed at underlying cause. So a sympatholytic agent, so something that inhibits the sympathetic nervous system. Calcium channel blockers can slow down heart rate and heart muscle contraction, and these can all help decrease this sinus tachycardia. So we can tell this is sinus tachycardia right away because, for one, we see our normal waveform. So we got our P wave, QRS wave, and T wave. In fact, what's interesting is that these electrical events are so close together, the T wave and P wave actually summate. They're kind of stacked together here. So here's the T wave, and the P wave is so close together, it almost looks like an extra hump on the T wave, but actually this is just the P wave that's occurring even before the T wave is finished. So seeing what our heart rate would be here, we count then are the number of big squares between each of our QRS peaks, And what we find then is that it's about 2 large squares between each peak. So 300 divided by 2 is 150. So there's 150 beats per minute approximately, just based off this ECG strip. And that would be defined as sinus tachycardia. Now, sinus bradycardia is where you have a heart rate that's lower than 60 beats per minute, and it can be normal in sort of physically trained individuals that have large resting stroke volumes. In trained athletes, their heart muscle can contract so efficiently that if their stroke volume is really high, then you can get the same amount of cardiac output with even lower heart rate because of stroke volume is so high. So this can actually be from also excessive parasympathetic nervous system activation. So if the vagus nerve inhibits your heart too much, that can lead to sinus bradycardia or a heart rate less than 60 beats per minute. Or, if so, slow heart rate can precipitate as low cardiac output. And the way you could treat this then would be things like sympathomimetic, so drugs that can sort of mimic the sympathetic nervous system and increase heart rate and muscle contractility, or parasympatholytic, or drugs that block the parasympathetic nervous system. That we can all act to increase heart rate and cardiac output. So looking at an ECG strip of sinus bradycardia, well, we see P, QRS, and then a T wave here. But if we count the distance between each of these peaks, what we find then is you have 1, 2, 3, 4, 5, 6, 7, 8.5 or so, and 300 divided by 8.5 or so would be in the 40s range for the heart rate. And so that's defined as sinus bradycardia. Now, sinus arrhythmia here is going to be a fluctuation in the heart rhythm during rest, and it can be pronounced in children. Now, this must be differentiated from sick sinus syndrome, which we'll talk about. And sick sinus syndrome is a more severe form of arrhythmia that requires more of a pacemaker. And sinus arrhythmia is pretty common in individuals, adults and children, but it's typically benign, shows no signs or symptoms, but it can be identified underneath an ECG. So if we look at sinus arrhythmia, which is up top here, and you look at these intervals, what you find then is these intervals are varying. You can see that this interval and this interval are much longer than these intervals right here. And what's interesting is this happens to be associated with the normal respiratory rhythm. And so sinus arrhythmias can change while someone's breathing. And so it turns out that your heart rate can increase while you inhale and then decrease while you exhale. So these longer intervals could be while the individual's exhaling here, and these shorter intervals could be where the individual's inhaling. And they're not like dramatic enough to cause any sort of pathology or disease process. So sinus arrhythmia is benign. But we need to differentiate this from sick sinus syndrome, which is actually on the ECG strip below here. And you can tell this is sick sinus syndrome because these intervals are way too varying. Like you see that this interval here is approximately 10 times larger than this interval here. And by having such large intervals, it leads to large fluctuations in cardiac output that aren't really effective at keeping adequate blood pressure and blood flow. And so this would need to be corrected with a pacemaker to make sure that this individual has a normal heart rhythm. Now, sinus arrest is a complete absence of any sort of electrical impulse. What we find if someone does enter sinus arrest or flatline, they can enter what we call an escape rhythm, which is more of like a slower pacemaker that can begin after that sinus arrest. And then this can occur, several seconds after the arrest, and that could actually bring them back to a normal rhythm. With a sinus arrest, this might require the use of a pacemaker, and it's a misconception that if someone has sinus arrest, that using the electrical paddles to shock their chest and shock their heart back into beating. Actually, those paddles are actually better for arrhythmias, not sinus arrest. So, you see on TV how if someone is flatlined, they'll shock their chest, but that's actually going to be a misconception. Sinus arrest is not correctable using those paddles. So what we find here then is just no electrical activity, hence the flat line here. So we call this sinus arrest or electrical asystole. Now we're going to move on to talk about the cardiac dysrhythmias, and we'll start with atrial flutter and fibrillation. Now, flutter is manifested by a rapid atrial rate of like 240 to 350 beats per minute of the atrial contraction. This causes a sawtooth pattern, and there's different types. So type 1 would be 240 to 350. Type 2 would be over 350 beats per minute. But I'm talking about the atria here, not the entire heart rate. And fibrillation is going to be where it's completely disorganized and irregular atrial rhythm that can be accompanied by an irregular ventricular rhythm. This is more dangerous than atrial flutter because fibrillation can lead to the production of thrombi, which can dislodge and turn into embolisms that can block the pulmonary or systemic circuits. So how do we differentiate flutter versus fibrillation? Well, we see atrial flutter here as this sort of rapid sequence of P waves, and then we have a QRS wave, and then these rapid sequence of P waves and a QRS wave. And it's considered flutter because we have these complete and separate P waves that are occurring. Atrial flutter is not as severe as fibrillation. Fibrillation, where you have completely disorganized P wave activity, and you can kind of think about this as being associated more with just really rapid contraction of the atria that really don't cause a nice complete contraction. And these rapid contractions of the atria cause enough disturbance in blood flow within the atria that makes the atria more prone to forming blood clots. This is why the fibrillation is more dangerous, as it can lead to thrombi and embolism formation. You can see this is AFib, or atrial fibrillation. Now, the ventricular dysrhythmias include things like premature ventricular complexes, or PVCs. These premature ventricular complexes will arise from the ventricular myocardium. They don't activate the atria or depolarize any of the nodes because these action potentials won't flow back to the atria. But what this does cause, though, are sort of bizarre-looking QRS waves. And if these ventricular dysrhythmias become too rapid, cardiac output can be compromised because the ventricles might not be able to completely fill with blood before they contract again, which means stroke volume and ejection fraction would be compromised, and so cardiac output would also decrease. So what a premature ventricular complex looks like then is we have P, QRS, and T wave. Okay, that's normal. But then what is this thing? So we see this big old PVC here. This is the really bizarre QRS wave. So this is a little QRS wave here. This is part of the T wave, actually, that's associated with it. And you see this inverted QRS and then a large T wave, which is associated with this PVC, or premature ventricular complex. And you see there's no P wave that accompanies this, which means it just arises spontaneously from the ventricular myocardium without the atria actually having any electrical activity associated with this ventricular activity. Now, if these PVCs become too frequent, what this can lead to are rapid ventricular contractions that limit cardiac output. Now, this differs from ventricular tachycardia because VTach, or ventricular tachycardia, is 3 or more consecutive ventricular complexes that occur at a rate of faster than 100 beats per minute, hence the word tachycardia. But the ventricles are contracting faster than 100 beats per minute. This can also be fatal if it's not managed because this can also really limit cardiac output. What we find then is that P waves are not associated with these QRS complexes, and the ECG really depicts a series of large, wide, undulating waves. So this is really characteristic of VTach, or ventricular tachycardia, and this would need to be, reversed either with a pacemaker or drugs or some other sort of therapy in order to improve cardiac output. Because if this VTach persists too long, cardiac output can be diminished too much. And so this differs from ventricular fibrillation because fibrillation, like we talked about atrial fibrillation, were these rapid, uncoordinated cardiac rhythms that result in ventricular quivering. So instead of having a nice complete ventricular contraction, the ventricles just kind of quiver and don't effectively pump blood along. So what this looks like then on the ECG is just a rapid, erratic electrical activity with no identifiable QRS complexes. This can result in death if it's not reversed within minutes because this leads to such dramatic decreases in cardiac output that it can be fatal. So this can be fixed with like defibrillation, CPR, or anti-arrhythmia drugs like calcium channel blockers. So this is what ventricular fibrillation looks like, or VFib. And so VFib is actually more severe than VTach because what we find then is that there's just not enough ventricular contraction to increase stroke volume and cardiac output. So this can lead to heart failure. Now, some other dysrhythmias that can occur can be due to blocks. So disturbances of atrioventricular conduction can lead to block, we call AV block, and it's a problem of communication between the atria and the ventricles. Now with blocks, it can be either slowed or completely blocked, where if they're slowed, it just could be where electrical activity just takes longer to get to the ventricles, or if they're completely blocked, it could be where the atria and ventricles just have electrical activity that just does not communicate. This can come from defects in nodes, bundle His, or bundle branches. And there's three main types of block. We got first degree, second degree, and third degree block. A first degree block is characterized as just a delay between the P wave and a QRS wave. So what we'll find with the first degree block is you have a longer PQ interval. And this is different from a second degree block, because with second degree blocks, this is where you might have a problem of conduction between the atria and ventricles, where you can have a P wave that's not conducted, and so you find at least one non-conducted P wave, where you have a P wave not followed by a QRS wave. And there's types 1 and 2, which will differentiate. And third degree block is where you have a complete blockage of electrical activity between the atria and ventricles, where the atrial electrical activity is completely separate from the ventricular electrical activity. So first degree block, remember, is just a delay between the P and Q intervals. But we're going to start out talking about the second degree blocks. So type 1 and type 2. With a type 1 second degree block, what we find that is a progressive prolongation of the PR interval, and one P wave should not be conducted. And if at least one P wave is not conducted, and there's this progressive increase in the PR interval, what we find that is we consider this a type 1 block. So type 1 second degree block. Type 2 secondary block is where you have a consistent PR interval, but with several non-conducted P waves. And this is more serious because it has a tendency to progress to complete block. So this we're seeing as an ECG of type 1 secondary block. And what we find is we see P, QRS, T, P, QRS, T. If you look at this, the distance between this P wave and QRS wave has an increasing interval, until what this leads to is that we have a P wave, and then there's non-conducted QRS wave. Okay. Now what we count here, there's only one non-conducted P wave, so we consider this a type 1 secondary block. Now that's different from a type 2 second degree block, because what we see here is our P, QRS, T. Then we have P wave, non-conducted, P wave, non-conducted, and then P, QRS, T. So because there's multiple non-conducted P waves, this is considered a type 2 second degree block. And this is more severe because type 2 second degree blocks, at least in terms of the epidemiology, are more likely to progress into a complete block, which is a type 3 block. So with a complete disturbance of atrioventricular conduction, we call this third degree or complete heart block. And it's diagnosed when there's no apparent association between the atria and ventricle activities. And it's more serious because it can lead to slow ventricular rhythm and poor cardiac output. So when you have these P waves that are non-conducted, that looks similar to type 1 or type 2 blocks. But then we also get these QRS waves that look sort of more bizarre. And the reason why these QRS waves look more bizarre is that they're occurring independent of atrial activity, which makes them look differently. So this third degree block is identifiable because the QRS and T waves actually just look differently than normal, as well as these non-conductive P waves, which altogether tells us that there is a complete dissociation between the atria and ventricles. Now you find more P waves than QRS waves with this third degree block because the SA node has a more quick intrinsic heart rate, whereas the heart rate that's generated by the ventricular myocardium is slower, like in the order of 40 beats per minute, whereas the SA node activity is more of in the order of like 100 beats per minute, which is why you expect to see more P waves non-conducted than any sort of T waves on here.